history. So this is a 53-year-old gentleman who presented with urinary obstruction and erectile dysfunction.
There's a mass. Any history of lymphoma?
No history of lymphoma. So enhancing mass, and then there are some others.
Multifocal.
Very heterogeneous, and also showing restricted diffusion.
Sai said, how about Copper's duct carcinoma?
Okay, so I know this is not fair because we have a path and he's had surgery. So let me just show you the other imaging that.
Peter, where are the other lesions? I only see the one big mass.
Yeah, so I mean these.
Oh, I see, in the shaft, okay.
Yeah, there.
David Fetzer is also saying prostate metastasis.
Good thought. Any other thoughts about on the same lines for metastasis?
It's like RCC.
Okay, so let me show you. So this was 3 years earlier. This is how he presented. This is after treatment.
Oh my goodness. Wait, is it rectal?
Yep.
Oh my gosh.
So thoughts about what this could be?
Is it a squamous cell of the rectum?
I'm sorry?
A squamous cell of the rectum?
Nope. Somebody had shown a similar case, actually twice in the last month or so.
Of the rectum? Let's see.
A mucinous thing.
So this is 9/2/2010, and this is 3 months later. So
it got a lot smaller. A GIST?
A GIST, exactly. So
what?
It was a rectal GIST, which was treated and then surgically removed in 2010, and then the patient presented 3 years or 4 years later with what I showed you, and he was biopsied. So it was a metastatic GIST to the penis, and then this is what happened following that. So again, it got smaller after he was treated with chemotherapy, and it got better.
Did they use Gleevec or did they use?
They used Gleevec in the beginning.
Oh, I see.
And then they operated him. So again, this is 2014, this is 2015. And then a few months later, the disease just basically cut loose. And he developed bone mets. And then this is what happened after, in just a few months.
Mike Adams said radiation sarcoma.
So all this
that before the GIST reveal, but yeah, that's crazy. What do you because normally GIST likes to met to
the liver and the peritoneum commonly.
Exactly. Yeah. Yep. So what do you have a theory of why it went to the penile shaft? Like maybe it went through the seminal vesicle, like.
Maybe. I mean, we just had like absolutely no idea why. We had never seen anything like this before. And he had mets everywhere, even in the lungs and
wow.
Just
yeah, so at that point it's hematogenousous, but I hadn't seen the...
So, I mean, as you can imagine, he didn't really do well. So,
Dr. Jambhekar, on the T1, did the lesion, I thought that it was T1 hyper. Was it due to biopsy or is it a known?
Let me just go back to the.
You're asking if it was hypervascular?
No, I thought it was hyper intense on the T1 pre-contrast images.
So this is a PATSAT T1. That's the only one I'm really showing you.
Okay, the primary lesion that you showed us in the rectum.
In the rectum. No, I mean, this is in and out of phase, and really there was not much of hyperintensity. And then this is post-treatment. So it was just like
Okay.
a well-defined lesion which showed enhancement.
Right. Nice case.
Okay.
So, I mean, it was unusual. One of our surgeons actually wrote it up. And I just wanted to share, just 1 second if I can find it. Okay, just
We can do a series from just the rectal GIST that have been presented here.
so I mean, this was just a little bit about rectal GIST. So GISTs arise from the interstitial cell of Cajal or its precursor, and then of course the most common is it's the most common mesenchymal neoplasm. So they express CD117, and they recently have shown that they also express GIST1 or DOG1. I'm not sure what this is. And sorry, if I could go to the next. Oops, sorry about that. Okay, so they can be divided into different categories, and basically it is based on the size and the mitotic count. And the interesting thing in this patient was his rectal tumor was removed, and he had less than 1 cell per high power field. So it's even more unusual as to why he metastasized like the way he did. And then when a penile tumor was biopsied, it had over 100 cells per high power field.
Maybe it transformed, or like it just killed off all the low-grade lesions and only the aggressive ones grew.
Probably.
Yeah, another thing, I really like this gistal risk classification system, but it's tricky because if you treat it with Gleevec, like when you get the final surgical pathology, it's not accurate because it's already been treated with Gleevec.
That is exactly actually what pathology said.
Yeah, so like if you've killed off like a lot of the tumor, then you're not getting the accurate staging.
Yep.
But if you get it from the initial biopsy, or if it's still very, very active when they resect it, that can be really good. They actually give a nomogram, and they'll give you a percentage risk of recurrence. And I always look that up because it helps me tell like my pretest probability when I'm reading a follow-up scan, like, oh wow, this was a really bad gist. I should like look everywhere for a met, versus a small little 2 centimeter, stomach gist that never got Gleevec and had very low mitotic index.
Right. I think that's a very important point. And the first biopsy in this gentleman was outside, and I just couldn't find it in our system. So they actually say that this is probably related to Gleevec. So I should have made that point, but that was.
I had a question about this case and in general for hypervascular mets. What protocol is ideal? Do we scan in the arterial phase, abdomen plus pelvis, or just scan the liver in the abdomen and follow it by a portovenous phase, or do both for both?
I think my group actually looked into some literature about that, and there was not a huge benefit for the arterial phase. Like I think for neuroendocrine tumors and some melanomas, it's very helpful, but we decided for sarcoma and GIST, it wasn't really adding much. And so because we were always able to see the mets on the other phases.
But in melanoma, do we like do full abdomen pelvis in the arterial, or like which one's preferable, or just the liver?
It's a big question. I mean, I even think MRI is just so much better for a high-risk melanoma than even a arterial phase. And with the MRI, you're going to get all those phases. And a lot of people now are advocating for EOVIST for the melanoma MRI. So if it's a high-risk one, like all these like uveal and ocular melanomas and stuff. So I personally prefer MRI with the arterial phase.
When we follow our cases, melanoma cases with CT, we do biphasic.
We do biphasic, but for CT for a while, but I don't know. Sometimes like if it's been years and years and years, I'm like, we need to stop radiating this patient this much, if they have no mets.
Makes sense.
Thank you.
Is my screen good?
Yes.
Okay, cool. This is an eye test. I mean, I was so impressed with the call that my colleague made. Eye test. Superb call. I mean, it was just like blew me away, and the path confirmed everything, even the length.
There's something like hyperdense in the pancreatic head region.
Focus on the bowel.
Okay. And I don't know, I feel like the TI looked funny. It looks funny to me too.
Yeah. What do you think about the TI? This is an interrography. Is anybody? So there's
stranded, almost feels slightly desmoplastic, like some areas are like brought together.
Yeah, right here, right? So there's like thickening. This is the TI is, where is the TI? It's like right here. There's the TI. There's a cecum, and the cecum, there's this like really subtle thickening and enhancement. So this was called prospectively, and this turned out to be cecal cancer on surgery. It's a really great call. What? Oh, yeah, it was adeno. It was cecal adenocarcinoma, yeah.
Okay, I have a quick case. Okay, you can see my screen, right?
Yep.
Okay, this is not an eye test. But I will ask you what you see anyway.
The gallbladder fundus, there's a mass.
Yeah, exactly. So what do you think it is, Nelly, or anyone?
I think it's malignant. I mean, I don't think it's not. I mean, we don't have MR, but Kedar says lymphoma.
Lymphoma. Okay, good. So we're thinking that this is some kind of malignancy, maybe lymphoma. I don't know why I can't scroll. Okay. And it was a little bit, it was interesting. So it looks like a mucosal, Mike Adams is saying Mets. So it does look kind of multifocal, and that there's like multiple polypoid kind of areas here. And even down here, like it's kind of like carpeting with like multiple polyps. So it doesn't necessarily look like one mass or like multiple polypoid masses. So when we showed this in tumor board, one of the surgeons said, "Oh, I think this is an ICPN." And I wasn't that familiar with it. And it turned out that this came back as moderate to poorly differentiated adenocarcinoma in the setting of an ICPN, which is kind of like the gallbladder equivalent to an IPMN. So I just wanted to talk about that a little bit. So this was the path. It was a rising and extensive papillary hyperplasia with high-grade dysplasia and this ICPN, which I'll talk about a little bit more. So ICPN is intracholecystic papillary tubular neoplasm. So the parts that are similar to an IPMN or an IPNB is like the intra part, except instead of ductal, we're going to put cholecystic for gallbladder. And then papillary, and then they add this tubular part. And actually the tubular part is the part that ends up being often an invasive tubular adenocarcinoma. And then the neoplasm is the same. So these parts are the same. So basically the point is you can get a papillary frond-like mass-like tumor in the gallbladder that is similar to IPMN and IPNB. And it's the same thing where it doesn't necessarily have to have cancer. It can have low-grade dysplasia, moderate, high-grade dysplasia, or cancer. There's two different types, just like IPMNs. Actually, IPMNs have even more types than this, but for ICPN, you have pancreatic, biliary, and intestinal. And just one more point, which is about polypoid masses of the gallbladder. So there's three main polypoid masses of the gallbladder. One is a polyp, and those often we see incidentally in the gallbladder, and generally, at least based on a radiology paper from a few years ago, I don't follow them if they're greater than 6 millimeters. Another is an adenoma, and these adenomas are different than GI adenomas. They're not actually thought to be that much of a precursor to malignancy. They're actually thought to be like hypertrophied pyloric glands. And the other is an ICPN, which is this like papillary tumor. So I know we're not pathologists here, but if I were to say one of these is a cholesterol polyp, which one do you think it is? 1, 2, or 3?
1.
Yes, good, excellent. So this is our cholesterol polyp because it's basically lipid-laden macrophages and the mucosa is intact. So this is what gallbladder mucosa looks like, and you can see it's just this single thin layer of cuboidal cells, and it's totally intact. There's no cancer here. And
You talk like a pathologist, though.
Huh?
You talk like a pathologist, though.
Well, anyway, I just rebought. I love this WHO pathology book. If you guys ever go on Amazon, you can buy it yourselves. And there's a 2019 version for GI. So that's where I get a lot of my pathology information.
That's totally geeky.
No, it's great. It's like totally like shakes my world because it gives you real percentages of things because all these tumors, pathologists like report them to the WHO. So it has like really good actual, like, and it tells you why things look the way they do. But anyway, so this cholesterol polyp, normal mucosa, and then lipid-laden macrophages underneath. So you can see this is totally different than an actual tumor, even though radiologically, they both just look like polyps or polypoid masses. One key is that the cholesterol polyps are much more common and then they're gonna be much smaller. This is an adenoma. It is not necessarily pre-malignant. It's basically pyloric glands. So anytime you see like a bunch of purple cells forming a gland, you see these are gland forming because they have a duct in the middle of them. This is what pyloric gland adenomas look like. And these tend to be larger. They're completely different than a cholesterol polyp. Radiologically, we can't really tell the difference. And these are usually incidental and associated with gallstones. And then this is our ICPN, which is a true intraductal cholecystic papillotubular neoplasm. And it has like these folded papillae and fronds, and then it leads to dysplasia and eventually invasive adenocarcinoma that'll invade the actual wall of the gallbladder. So that's my
Awesome.
treatise on gallbladder polyps. So I said one case I saw was hydropic distension of the gallbladder with mucin. Was this gallbladder filled with mucin? That's a really interesting point. They did not comment on that. I can ask my pathologist. One thing that's interesting is the IPNB and this ICPN, if you notice, unlike the IPMN of the pancreas, they don't have mucinous in their title. So even the IPNB of the liver, it can be mucinous, but it can also be non-mucinous. So I would actually assume the same of this of these gallbladder lesions.
Awesome.
Okay.
I have to go. So we're going to, this next week, once a week, right? Next week, Tuesday?
Yes, and actually next week, Tuesday, Nicole Heineman is going to join us and give a research tips lecture that's particularly for early career attendings and residents and trainees. So we're having a special session next week.
Cool.
Okay.
Wait, see you next week.
Bye, guys.
Bye.